think first off, I want to get the session started with our first speaker. And we have Dr. Robert Gish. Dr. Gish is currently the adjunct professor of medicine at Stanford University in Palo Alto, as well the adjunct professor of medicine at University of Nevada School of Medicine in Las Vegas. In addition, he's also the medical director of Hepatitis B Foundation and the medical director of the Asian Pacific Health Foundation. You know, as Kathy mentioned, he's really been involved with PBCers pretty much since the start for a long period of time. And they really appreciate his information and advice. And today, Dr. Gish is going to be talking about the current treatments for PBC. So I'd like to welcome Dr. Robert Gish.
Good morning, everybody. I tend to like to walk around and not sit behind a podium or stand behind a podium. I think it's like a barrier between us, so I want to be a little closer to you today, if that's okay. And definitely want to thank Kathy and Lenny for all the work they did and all the interactions, and definitely warning me about this meeting far enough ahead of time that I could be here, because my life is scheduled about 6 to 8 months in advance, so I'm very, very thankful. I want to thank also the different organizations that help support this. I work very closely with Intercept. I've had recent interactions with Arena and Simibai. It's really good to see so many companies investing in this space, investing in us as providers, but more importantly, you as patients. I'm the first speaker because I told Lenny and Kathy I had to get out of here quickly because I have another event tonight in San Diego. I work for an FQHC called La Maestra. And it's their annual event, so I have to get on a flight around noon. And what I'd like to talk about today is management. This is really a treatment talk. So we're going to jump ahead of epidemiology and diagnosis and everything. And there's about 60 slides here, and I'm only going to have 30 minutes. I really want 15 minutes for Q&A from all of you. So I'm going to give you a tour of these slides. They'll be posted on my website later today, and that's very easy. It's just my name, robertgish.com. Of course, it's going to be recorded and posted on the PBCers website. And if you have any questions, you can go through my website and send me questions. You also can get on a listserv on my website for updates on liver disease. So I'm glad to help in any way I can, and thank you all for being here. And let's dig into things just a little bit. So this is a good slide. Just basically, we're going to talk about PBC as a disease state. I'm not going to just talk about the liver disease. And I want to really talk about management steps. And as we get into that, it's about managing the liver disease, but managing the patient as a whole, managing all of your symptoms, your quality of life, your family members, your loved ones' quality of life, and then other medical issues that revolve around PBC. Maybe we have these problems with lipid disorders that might be a problem. We might have bone disease that's a problem. Hear a magic beeping noise. Still not going forward, though. Okay, good. So we really have to look at any patient with liver disease as a complete patient. We are dealing with fatty liver now. We have to look at the whole patient, diabetes and hypertension. Hepatitis C affects the whole body. PBC affects the person, affects their family, affects their work, their quality of life, and can lead to a variety of other problems. So this is very simple. I'm going to live with this PBC definition: elevated alkaline phosphatase, positive AMA, or compatible liver biopsy. It's very, very simple. You'll hear more about that some of the other speakers. But this is where it gets really important. When I hear the word PBC, of course, I'm immediately staging that patient's liver disease by labs or doing a physical exam. But I'm working my way down this list immediately. How much is itching affecting your life? Dry eyes, dry mouth, teeth decay, giving every patient advice on dental care, oral care, abdominal pain, looking for jaundice, looking to see how bad their fatigue is, their functional level. Something called restless leg syndrome, where people's legs move at night all the time. That's something that's part of PBC. That really disrupts the sleep disorders that we may see in some of our patients and add to itching, of course. The insomnia is an interconnect of these, as well as depression, which makes sleep disorders even worse, and we can treat that depression directly. And then this cognitive dysfunction, this mental fog that patients have. I think a lot of that's amplified by the sleep disorder, but maybe also part of the inflammatory disease that's present. So we have long-term care. We're going to be structured. We're going to be individualizing this. This is personalized medicine. And then we're going to be talking about the liver disease as well. Now, how do you like that slide? This is all in one. I got this off the EASL practice guidelines. EASL was great. It was in Paris a few weeks ago. And as the meeting rolled out, they rolled out a series of new practice guidelines. And immediately they had a set of PowerPoint slides that were downloadable. So I'm a really big believer in PowerPoint. So I put together this huge slide deck, which I'm not going to dig through every one. We don't have time to do that. But please, when you get home, download this deck and look at all the different parts of this. Some of it's a lot of technicality and science and other things. Look at this incredible flow chart that you need to be thinking about. I need to be thinking about with each patient. So there's some special comments I want to make on here. There's a new test called elastography, which you all should be aware of. It's a way of staging liver disease. It's an annual test. It's inexpensive. It's sort of like an ultrasound that measures the stiffness of the liver. So we don't need a liver biopsy every year or every 3 years. We can decide if someone's progressing or regressing using a non-invasive test that just takes just a few minutes. Another thing that I want to highlight on here is what we call liver function tests, bilirubin. So a new point to some of you, a new teaching point, is that it's not the total bilirubin that's the story. It's something called the direct bilirubin. Who here has heard of direct bilirubin? Raise your hand. Oh, maybe a third. All right. So now everybody can raise their hand. Who's heard of direct bilirubin? All right. So we're at 100% now. So the direct bilirubin is part of the bilirubin assessment where we fractionate that. We split it into indirect, which is a type of bilirubin that floats around and it basically gets into tissues really easily. Or the direct, which is conjugated. The liver puts the bilirubin together with another molecule so it can go out in the urine. That conjugation, that direct, tells you how good or how bad your liver function is. It's the best liver function test, and it should be 0.3 or less. Once it's 0.4 or 0.5, that means there's significant liver dysfunction. And this is the first test that will become abnormal in most patients. Albumin and INR are good liver function tests. Remember, AST, ALT, alkaline phosphatase, GGT, are not liver function tests. You're going to need to retrain the trainers, who are the doctors, the providers you work with. Those are not liver function tests. They are liver enzymes. They're markers of inflammation or damage. A lot of other things in here we'll get into, but I just wanted to highlight those, and we're going to talk about treatment again shortly. So we've done a lot of research about medication options, whole series of medications that were unsuccessful, questionable. There was a very interesting abstract at EASL from Gideon Hirschfeld on budesonide that showed some changes in enzymes, but didn't look like it helped the liver very much, so I'm going to put that in the middle column. And then we have useful, I'm going to call this very useful. We've got UDCA, URSO, first line. We have OCA, the second line or first line, because if you have somebody who's URSO intolerant or may have failed URSO for other reasons, OCA can actually move to a first line, obeticholic acid. And I just want to remind you all, there's 20 different ways to pronounce this drug, but Ocaliva is the correct way. All right? I have heard 20 different ways of pronouncing that. We have some exciting new information on these fibrate drugs. There was a very big study a year ago at EASL with some updates called bezafibrate. It's not available in the U.S. And then fenofibrate, which is available in the U.S. as an option for treatment. This is off-label, but there's some very provocative new information that may really help enzymes and may even be helping liver injury, liver inflammation. And I am considering that in some patients. I haven't actually put anybody on it yet, but I'm very close to starting that because this data looks quite compelling. And then, of course, research trials. Anybody who's got PBC should be looking at new research opportunities, new medications that are coming out, especially if you're failing our two first, second line medications. All right. Where did we get the information on ursodiol? A large number of randomized trials. Some of these going out 9, 10, 11, 12 years, over 1,000 patients. But it was kind of messy because we had different doses, different endpoints, different timelines that were there. And this beautiful little graph that looks sort of like a ladder, basically, if you're left of the line, it works. And that's what this is showing here by combining all these different studies. We're combining analyses in two different ways, that the chance of dying or transplant on URSO decrease. It is improving life. It's improving lifespan, decreasing the chance of transplant. But this took 5 to 10 years to figure out because the first few years of urso didn't show any difference. And people almost gave up on it, except Dr. Poupon never gave up on it. And he kept doing studies longer and longer. And the curves started separating. And those are the curves we think about as providers of living or not living or transplant or not transplant. Seemed to make a better difference in patients with cirrhosis. But again, follow-up at 5 to 6 years was too short. And that's where we really started getting that data out 5, 10 years and beyond, where urso is really showing a difference. So we want to improve quality of life, liver disease, survival, most importantly, decrease the need for transplant. And the number of people getting transplanted with PBC continues to fall. And these are because of interventions, historically, urso and current, and I believe inferentially, OCA, obeticholic acid, Ocaliva is also going to have that effect. It's inferential now just because we're looking at changes in liver enzymes, specifically alkaline phosphatase. But the biggest point I want to make to you on this slide and through the talk is that the goal is to have a normal alkaline phosphatase, not this 1.67 or not 15%. In our lifetime and treating our patients, we want to get to that long-term goal. It's not necessarily happening in a lot of patients yet, but eventually we're going to try to get our alkaline phosphatase under 120 in every patient. And I'm going to raise a question is, what is a real normal alkaline phosphatase? What's a healthy alkaline phosphatase? AST and ALT in a woman should be less than 20, not 40, not 45. An ALT in a man should be less than 30. So we're probably going to come up with what a real healthy alkaline phosphatase is. But for the short term, I love 15%. I love 1.67. But I like even more normal, less than 120. And I believe a lot of patients may be better living at 60, 70, or 80. But we're going to be looking at that over the next few years. This is a little bit more data here on urso in terms of survival, patients who are on placebo who are changed to urso. And the higher the line, the better the survival. We can make alkaline phosphatase better. We can decrease bilirubin. We've shown delays in progression and reversal of fibrosis. Decreases risk for development of esophageal varices. Those are the big veins in the esophagus that we look for in our patients. And increases liver transplant-free survival, the interval between. So urso, we've got the data. You're going to hear more about that from other speakers. Don't you love all this? Endpoints. This is how fun it is. I'm being a little facetious. How fun it is to be a researcher because everybody wants to come up with either Paris or Rochester or Rotterdam. They all have their own different endpoints. But we want the bilirubin normal. We want the direct bilirubin 0.3 or less. We want the alkaline phosphatase normal. These both are near and long-term goals. But any decrease, I'm saying just a mild decrease in alkaline phosphatase of 15% is associated with better outcomes. You hit that next goal of 1.67 times the upper limits of normal, very simple number, 180, improvement in survival, outcomes in patients. I think we're going to get even better as we get to normal alkaline phosphatase over time, and that's the simple thing that you need to remember through all this complex information that's on this graph. Now, urso, pretty benign drug. It's natural, right? When it's synthesized, but it's just the same thing that comes out of bear bile. Bears sleep through the winter and they don't get gallstones because they have this beautiful bile acid, right? So now we've been giving it to patients, but it does cause problems. Abdominal pain and discomfort with diarrhea. Hair loss, I've seen that in at least 2 to 3% of patients. Nausea can make itching worse. It can cause a rash. I've had other patients even have worse side effects from urso than what I've listed here. I didn't know about this, weight gain in the first year. That may be good for some patients and bad for others, but I thought that was interesting. And, of course, this is contraindicated. You're not going to give OCA or urso to anybody with biliary obstruction. So this is from the EASL guidelines, and they're talking about first-line therapy and then talking about using OCA, Ocaliva, in patients who fail urso or can't tolerate urso. And this is high level grade and evidence grade of recommendation. Very high quality studies have been done to support using these medications. That's the message on this. So what's new about obeticholic acid? Let's just get into a few comments here. We're talking about alkaline phosphatase reduction. As you know, we have accepted, we meaning providers, you as patients, regulatory authorities, see that alkaline phosphatase change as a surrogate for how healthy that liver is. Decreased inflammation, decreased progression of fibrosis, maybe even regression of fibrosis. We've got very, very good data on this alkaline phosphatase surrogate. So I want you to just keep that in mind. This is part of the POISE trial, and this is where I really like looking at things, and I'm looking at that total bilirubin decrease, right? I like inflammatory markers to decrease, but I want a liver function to get better. I'm seeing liver function tests improve. I even have more confidence that these medications are working and should be part of our armamentarium. So I think this is very, very important. Then there was a small study that was done within the OCA study group where they actually did liver biopsies and showed stabilization of fibrosis and improvement of fibrosis in some patients. These are short-term, small studies, histologically accurate. These are very well delineated biopsies, right size, the right number of portal areas. And we're seeing reversal of fibrosis in nearly half, got stabilization, and just a few patients getting worse. So this is very good information. I'm not recommending we get biopsies on everybody, but I think elastography is a very useful test to get done. And my patients with PBC, they're getting that done annually. All right, we're going to switch to pruritus, part of the PBC complex. And we don't really understand this, but I'm just going to go through a few things that I think are interesting about this. We know that PBC is attacking these small bile ducts with inflammatory changes and probably stopping different transport and metabolic events that are taking place at the bile canaliculus level. We're going to be seeing pruritus not just in primary biliary cholangitis, but stones, strictures, PSC, something called IgG4 syndrome that can mimic more PSC than PBC, and autoimmune hepatitis. And I have a patient that actually has all four of these that I'm working with right now. It's been definitely a challenge working with her and what medications to use and how to slow her liver disease. So there's something called autotaxin. This is an enzyme system, and it's involved with formation of something called lysophosphatidic acid, just called LPA. This is my favorite bad actor in pruritus. It's not necessarily agreed to by all specialists. All the people are doing research in this area, but I think the data that came out of some research from Holland was quite compelling. Autotaxin's an enzyme that takes something that's a choline derivative and moves it into an acid, and this acid's very, very irritating. In the POISE trial, the study done with Ocaliva, they didn't find a relationship between autotaxin and lysophosphatidic acid. So I'm not saying it's the answer for everybody, but I think it's one of the mechanisms that explains itching. And why that's important is people may be able to come up with medications that may target this, and we'll be able to figure out who has this enzyme activity that's a problem, that's increased, who has got more lysophosphatidic acid. We may be able to target them with some of the new therapies. And again, this is just showing what the structure looks like, and this can be very irritating to the nerve endings in the skin. It may also have a central effect somewhere in the brain. This stimulates cells to proliferate, may even have some oncogenic properties, and I want to make a point here. You've got PBC, you've got stage 3 fibrosis or greater, somebody you know has that. All those patients need to be undergoing liver cancer surveillance once a year, better twice a year, with an ultrasound and blood tests. So F3, yes. F4, absolutely. Liver cancer surveillance is important. All right, what have we tried? There's a very short list here. I'm going to refer you to my website. I've got a very nice 1.5 sheet pruritus worksheet that's got first phase, second phase, third phase to treat pruritus. My favorite actually is Atarax to start with in my patients, and primrose oil. Who here has heard of primrose oil before? All right, so I think that works. It doesn't work for every patient, but about half my patients get significant reduction. Mix that with a little bit of Atarax. Might make people a little bit sleepy, help them sleep at night. A great start. How many people in this room have tried or know somebody who's tried this cholestyramine, this bile acid? How many people in this room like cholestyramine? All right. One person raised their hand, maybe two. I never use cholestyramine. I'm almost never. Sometimes patients come in on it, they say they're stable, they're better, and I leave them on it. But I find it, it's sort of like swallowing sand 2 or 3 times a day. It's just not my favorite thing to do for my patients. And it binds and interacts with other different drugs. But this is the top one if you go to the European guidelines. And they say don't even use Atarax because Atarax or hydroxyzine doesn't work in Europe. I don't know why. But go to my website and you can work through this list. You can print that out and take that to your providers and have them work through that list. And there's drugs even as far out as rifampin or naltrexone that can really be powerful to reverse itching, but they got some complex issues. Sertraline, this is one of the SSRIs. There's a number of these antidepressants, but they have this really interesting effect on serotonin. They make people more happy, more energized, and they cut down on itching. So these are really nice compounds to help. Trazodone, there's another one of my favorites called Doxepin. It came out as an antidepressant. It has anti-itching properties. It helps people with sleep, and it's an antidepressant that's mixed in. So I have a very low threshold to be placing patients on a low dose of antidepressant medications. And these are just some different graphs showing improvement in itching and how much their quality of life improved, their pruritus scores. As you know, there's at least 3 or 4 different scoring sheets for pruritus. I usually don't fill those out on patients. I just ask them, how bad, what time of day, what makes it worse, what makes it better, how much is it affecting your family member's quality of life, and then I'm going to work with them to try to make that better. I'm going to say 90% of patients can get 90% better using this algorithm as you can work through that. Fatigue. I believe that in PBC, 90% of patients have significant fatigue that's affecting their quality of life. This is something that we think is a central process of something in the brain that's probably affected by inflammation, different cytokines, different markers. Urso doesn't help. I don't think OCA helps. But I think antidepressants and modafinil do work. Modafinil is one of these stimulant agents that's present and can really help people. So modafinil is an interesting drug that was developed by U.S. government in collaboration with a company called Cephalon because they found out that their Air Force pilots were using methamphetamines to fly to Iraq during bombing missions or Algeria or other places. And they said, we need something better than methamphetamines. Methamphetamine is addictive. So they figured out what methamphetamine did to the brain, actually of rats. And then they said, let's come up with a chemical that's better. And they did. And now there's a number of different drugs. There's at least 3 that are in this class. I use them when I go internationally for jet lag. It's much better than a couple cups of coffee for me. Coffee keeps me up for 24 hours. So this medicine does help some patients. The big problem is dollars. It's $12 to $15 a pill. And I haven't found a cheap way to get that. Maybe you have to bring it in from outside the U.S. But I think that modafinil really, really helps patients and really improves energy. And fatigue also seems to be appeared with worse outcomes. The more fatigued patients are, the more they're likely to progress or have events like transplant or liver failure. So that's where all these different slides show that you can take a look at. This is the effect of modafinil after 2 months on fatigue scores. This is pretty remarked reduction. A lot of people are in the 16 to 20 range, end up down around 4 to 6. So discuss this with your provider and decide whether that's something that you can use for managing your case. This is a sleepiness scale. It's FDA approved for shift workers, day-night reversal, and for narcolepsy. That's the way it's actually FDA approved. So it'd be very nice if we could figure out a way to get the prices down on this through some generics or bringing it in from Canada or Asia. All right, let's talk about a few other special issues. Minority of women with PBC are of reproductive age. Very important to know that URSO is safe during conception and pregnancy and postpartum, according to expert opinion. The grade of evidence isn't that good, but the level of recommendation, where you see this 1 over here, is quite high. Pregnancy in patients with primary biliary cholangitis with cirrhosis does have a higher risk of complications for the mother and the baby. So we're really advising women with PBC who want to get pregnant, if they've got cirrhosis, go on treatment. Let's see if we can reverse your disease before you decide on conception. Rifampin's even been used during the 3rd trimester for itching, what looks like very low risk. What else do we have to talk about here? This is just quality of life, pruritus, fatigue, the Sika complex. Those are all issues that we're working on. The grade of evidence here is relatively low, but the experts feel that they can take that low to moderate level of evidence and give some strong recommendations. That includes seek and treat that fatigue actively and coping strategies. And everybody's heard about the coffee story, right? How good coffee is for your liver. This is really a powerful message because now I can tell my patients I'm an herbalist, as I'm telling people to use coffee every day, whatever their liver disease is. This is anti-inflammatory, anti-fibrotic, and anti-cancer. So coffee, 1 to 3 cups a day, as long as it doesn't disrupt your night sleeping, is very, very healthy for you. Also statins, right? Statins, there's 6 or 7 different statins for lowering cholesterol. Used to have a really bad reputation. They even had a black box warning that they were liver toxic. Well, the FDA made a huge mistake. They finally took the black box warning out. Statins are now extremely fashionable with very good quality data that they're also anti-inflammatory, anti-fibrotic, and anti-cancer. There was a study at EASL in primary sclerosing cholangitis patients where statins had this profound effect on surrogates for outcome in PSC that looked quite interesting. So statins are safe, could be considered as treatment for cholesterol, hyperlipidemia, but also potentially liver protective. We're, of course, going to evaluate all of our patients for bone disease, and as part of that is vitamin A, D, and E levels, PBC patients, especially once that direct bilirubin's over 0.3. That's what I find is a correlate where fat-soluble vitamin levels start falling. I want that vitamin D level 40 to 50. I want the vitamin A level in the normal range. I want vitamin E level in the normal range. So all those fat-soluble vitamins, testing levels, and supplementing where necessary is going to improve bone health, skin, immune, antioxidant, I believe liver health. So I think those fat-soluble vitamins are a key part of managing patients. And then these bisphosphonates are also something that we think are safe and effective. And that's given a grade of recommendation of grade of 1. So DEXA scans every 2 to 3 years be considered strongly in patients in monitoring and intervene if there's osteoporosis or high levels of osteopenia that look like it's going to osteoporosis. Well, we talked about fat-soluble vitamins. We talked about treating hyperlipidemia. In PBC, there's a lipoprotein X that's increased, and sometimes the cholesterol can run 300, 400, 500. That doesn't necessarily mean there's a higher risk of heart disease. This is a lipoprotein that's not necessarily directly related to cardiovascular disease. But I went back and talked just about cholesterol in general. We also talked about the benefit of statins that may help PBC patients. So that needs to be discussed on a case-by-case basis with your provider. Other things with hyperlipidemia, I had a patient who I saw a long time ago who came in with a cholesterol of 1,500. Her brain wasn't working. She had the cholesterol that built up in her nerves that led to nerve entrapment. So occasionally PBC patients, especially those that are cholestatic, that have a high bilirubin, can get cholesterols of 400, 500, even over 1,000. Those patients may need to be treated with something called plasmapheresis, where we take that cholesterol off acutely through a pump and a filter system. So this really needs to be looked at in every patient and individualized. What's the family history? Do they have another part of metabolic syndrome, such as diabetes? Is there evidence of calcium in different blood vessels? So that it has to be a detailed discussion with your expert provider or a cardiologist that knows about PBC. Let's take a look. Portal hypertension, that's where we get dilated vein below the liver, dilated portal vein that results in varices. What's very interesting about PBC is that patients with PBC at stage 3, that's not cirrhosis, that's the stage just before cirrhosis, can get varices. So if you hear the word F3, stage 3, that's a signal that that patient needs to have an endoscopy. And then if there are varices present, we have interventions for varices. We have some different medications such as beta blockers or carvedilol that can decrease the varices. We can ban those varices, then decide how often to get endoscopy done after that time. We talked about liver cancer and surveillance, and I think about it at F3, definitely at F4. I'm thinking about twice a year, ultrasound and blood tests for liver cancer. Another important point we discussed is PBC as an indication for liver transplant is declining. That was first, I think, an URSO effect. The second wave is diagnosing PBC much earlier. And the third wave that we're part of now is obeticholic acid, which I think is going to have another level of benefit. But transplant definitely works for these patients. But the disease comes back in about 20% of patients. So we have to treat those patients a little bit more aggressively with immune suppression. There's an interesting study that if you put a PBC patient on URSO at the time of transplant, the chance of recurrent disease is lower. So I'm thinking about putting all my PBC patients on URSO after transplant long-term. It's definitely a discussion that I think about in my patients. These PBC patients are also at increased risk for rejection. They have a more active immune system, and if they get a transplant, I'm going to have them on a little bit more immune suppression. Let's see what else we need to talk about. This is just care models, basically putting together a complex, a pathway of care that moves forward with a team of providers, and make sure you're seeing a person with a specialty in hepatology or a special interest in PBC to manage or co-manage your case. All right, so these are clinical standards. We've actually gone through a lot of this, so I'm just going to leave this up here just for a moment and say we're looking at timing of transplant, endoscopy, quality of life, how to manage and measure progression or regression, how to manage bone disease, eye. Everybody gets a Schirmer test every year in my practice. They see an ophthalmologist. That Schirmer test measures tear production. They get a dental exam twice a year. They get dental cleaning. I'm saying floss your teeth every day, brush twice a day, use a water pick twice a day, scrape your tongue twice a day, and use some type of Listerine or mouthwash. There's 5 steps to good oral care in PBC, and each patient gets that information from me. Now, these are all the people and companies that have helped. There's others I didn't include here, but my patients and their families have helped me immensely. Really happy about the PBCers and the collaboration with the PBC Foundation that brought about the name change, as you know, a couple of years ago. That started with a meeting in London where David Jones kind of waved his hand and said, oh, we're never going to change that name. We've tried that for 20 years. And after about 20 phone calls between Lenny, myself, and Robert, and a number of other people, we started this tsunami, led to 7 simultaneous publications. And this was driven by the patients. This was driven by, listen to us, listen to what our concerns are. This name is wrong. This name is confusing. And there were a few holdouts in the hepatology world. I'm not going to mention their names, but I continue to give them a little bit of a rub every once in a while. Oh, yeah. Thank you for being part of this name change. So it was really good. These are really key people that have taught me a lot and shared slides with me. These recent EASL guidelines, the AASLD has their guidelines also that people need to be paying attention to and learning from. And I hope I've got maybe 5 or 10 minutes for Q&A. How are we doing? 10 minutes. Right. I think your question is there a long-term risk of using URSO? And nothing has been seen in primary biliary cholangitis, in my opinion. There was in PSC patients who were treated with very high-dose URSO, there were some bad outcomes that occurred, including colon cancer and actually an increased mortality rate. But those are at levels much higher than we would use in PBC. So I'm going to say, other than this list of somatic complaints, long-term risks are 0. Same thing with OCA. We haven't seen any long-term downstream risks of OCA. There are some very subtle changes in lipid profiles with Ocaliva or obeticholic acid, but we don't think those are clinically significant or can be managed with lipid agents. So right now, benefit is this much, and risk is so small I'm having trouble seeing it between my fingers. This is really, these two medications, the benefit-risk ratio is logarithmically multiple times higher. It's that simple. My name, no spaces, no dashes, and please join me there for newsletters. There's a lot of places to download information. There's educational videos on that website, and there's a link, of course, back to PDCers. So oils are really coming into style, I have to say. I've even tried them, and I don't see any risk to those oils in general. If you're taking oils, obviously a lot of them are applied to the skin. A few of them are taken orally. But this primrose oil is a natural plant-derived oil that really helps with itching, and I think it's got some characteristics of antioxidants. So no danger. And I think you just need to look at how they're benefiting you. My favorite is pravastatin, 20 milligrams a day. It has no significant drug-drug interactions, and it does not cause the muscle inflammation that you see with a number of the other statins. So to me, it's the safest, and it has, I think, a beneficial effect. Right. So cirrhosis, that's the trigger. So screening is the first test, and surveillance is ongoing testing. So surveillance should be every 6 months with an ultrasound. And I also order biomarkers. These are blood tests for liver cancer. There's a triple biomarker panel that's FDA approved. It has alpha-fetoprotein, AFP, AFPL, as in Lisbon, L3, and DCP. That's David, Charlie, Paul. Those three biomarkers together, I believe, are much better than a single biomarker in terms of long-term risk of liver cancer. They're risk markers. They're not for diagnosis. Ultrasound abnormal, you go to an MR scan. Ultrasound low quality in somebody with cirrhosis, I get a baseline MR scan, then decide how often to do ultrasounds. Right. Okay. Let me ask you a question. This is about how to set up your monitoring. How many people in this room have a laptop or a desktop computer? Almost everybody. How many people on your computer have the program called Excel? Almost everybody. Every single patient I have with autoimmune disease sets up their own Excel spreadsheet. On that Excel spreadsheet, you have liver enzymes, liver function, biopsy if done, what medicines they're on and when those medicines change. And then they have flags on that Excel spreadsheet when they need their surveillance done. So that spreadsheet comes to me every 3 to 6 months by email. I look at it with the patient and we decide what we're going to do next. Increase Ocaliva dosing. Do we need to add another drug? Do they have autoimmune overlap syndrome, which you'll be hearing? There's a lot through that spreadsheet, and you can monitor your case and care with your provider, with your internal flags when you need testing done. Make sense? So if you want a copy of a spreadsheet that's an example, you just send me an email. And my email is really easy. It's rgish@robertgish.com. And I'll send you a template. I've got a beautiful template that's all laid out. You would take the template, wipe out the numbers on it, because it just gives you some examples, and build in your story into that template. Absolutely. Yeah, but, let me just propose that. That's a great idea. Yeah. All right. Milk thistle will not hurt you. Milk thistle will not help you. And beets, I eat beets every week. They're great. Help me. Beets are healthy. Very healthy diet. Mm-hmm. Yes, so fog, fatigue, sleep disorder, itching, they're all tied into each other. I think the majority of that fog is, one, driven by sleep deprivation, and number two, by depression. And depression could be inherent or could be a reflection of the sleep disorder or some other problems that are going on. So I really want to treat the sleep disorder. Healthy sleep, much healthier body, much healthier brain. Focus on that and think about these sertraline, these antidepressants that help with energy and sleep. Remind me what Vyvanse is? Oh, like Ritalin. Oh, yeah, I've heard of that. I think they use it for ADD. I haven't had any patients using it. I think there's a slight risk of addiction to any of the methamphetamine derivatives, so you have to be very cautious. Work with your provider. I wouldn't say a yes-no right now, but I think there's better ways to approach this. And we've left out an incredibly important issue, which is exercise. Each of you should be getting 3 hours of exercise a week. That may be a little, that may be a lot. That probably is better done in the gym, swimming, walking. That should include a mixture of aerobic and weightlifting. Very important. That helps you sleep. When you exercise more, your sleep cycle gets improved. So endoscopy to look for varices, basically 100% sensitive. This test will pick up varices, will grade how big the varices are and whether an intervention is needed or not. And that could be a pharmacologic, a pill intervention, or banding the varices in some way. And that's at stage 3 is where we recommend the endoscopy. Pre-cirrhosis to start. So post-transplant, there's a higher risk of rejection and a 20% risk of recurrent disease. The recurrent disease can, over 10, 15, 20 years, destroy that new liver and theoretically lead to the need for a second liver transplant. It's not necessarily worse, but the risk of this rejection is something that's significant. So I keep patients on higher doses, typically on Prograf and mycophenolate. Those are 2 best immune suppressive drugs. And I run those levels higher and longer long-term and watch closely for rejection. Great question. So it's 12 to 15 milligrams per kilogram. We've all agreed on the best dose. And you can take it once a day or 3 times a day. Both the same. You get the same blood levels, you get the same absorption, you get the same exposure. But sometimes 3 at once, maybe 3 times 300 or 2 times 500, might cause some GI upset, and may be better to spread it out 3 times a day. But once a day, compliance is always better, as opposed to trying to remember 3 times a day, did I take it? Although there's some really nice pill boxes over here and reminder apps to take your pills, right? Right. So NASH is terrible. We've got probably 60 million people in this country with fatty liver. It's the new epidemic, the new leading cause of liver cancer, will be the leading #1 indication for liver transplant soon. And you can have PBC and NASH. You can have PBC, autoimmune, classic, and NASH. Sarcoid is a type of autoimmune hepatitis. I've looked at the literature. I found 17 different types of autoimmune liver disease. PBC, PSC, classic autoimmune hepatitis, overlap, autoimmune cholangitis, I'm not going to go through the whole list right now, but there are 17 different variants of autoimmune liver disease. And remember, one take-home message is every person with PBC needs to be monitored for celiac sprue, gluten sensitivity. Probably 5 to 7% of PBC patients have sprue, have gluten sensitivity, need to be on a gluten-free diet. So that's got to be part of your interaction, your family or loved one's interaction with their provider. Mm-hmm. I will agree with you. It's on the horizon. So lasers were in fashion. Everything was going to be cured with a laser, right? We've had a lot of fashions. Now, lasers still have a role, narrow role. We don't know what stem cells' role is going to be in autoimmune disease. So my recommendation is don't fly to China or Mexico to get your stem cell infusion. Watch for research results. Remember, stem cells are the stem of cancer. So we got to be careful about what stem cells we use and look at these very carefully. It is not something that I'm rushing any of my patients to get those tests done. But if I look at a very well-designed trial, I would say I would support considering that. But I'd have to look at the details of the research. Thanks. And by tomorrow, you will have no questions, right?
Great, thank you. And Gish, then we'll do it. Thank you, Matt. Yeah, good to see you again.